In this session, we're going to look at cognitive and behavioural aspects of addiction. Previously, we looked at psychoanalysis, which investigates the root cause of a problem, which often relates back to childhood. Cognitive behavioural therapies address the present-day issues. As compared to psychoanalysis, cognitive and behavioural therapies are usually short-term, and it's perhaps this quality which makes them appealing. However, in the book Welcome to Methadonia, the author writes, it can be very difficult for a heroin addict to unlearn a form of behaviour that's so deeply ingrained, yet drug counsellors assume that this sort of behaviour modification is possible. Literally and figuratively, heroin gets under your skin. Another point is about the nature of therapy. Again, in Welcome to Methadonia, the author writes, I found group work more effective and enjoyable than individual counselling. They tend to trust their peers more than their counsellors. The power, energy and leadership flowed from the clients rather than from me. So there are many issues to consider in this presentation. Motivational interviewing and cognitive behavioural therapies are two well-known approaches in this area. Motivational interviewing, shown on the left here, explores clients' point of view, their emotional reactions, the obstacles to change, what are their reasons for drug use, what are their strengths and weaknesses. Cognitive behavioural therapy looks at triggers and decision points, coping with urges and cravings, challenging distorted beliefs, and planning new routines. So motivational interviewing is sometimes thought of as an adjunct for treatments such as cognitive behavioural therapy in order to increase motivation for and commitment to the intervention, especially when components of the treatment, for example, cognitive restructuring, may be challenging. Motivational interviewing has been called the second most effective approach after brief interventions. By brief interventions, we mean, for example, just a simple chat with a GP. A doctor may simply review the amount that a patient drinks or use a checklist to evaluate the extent of a drinking problem. The doctor then typically recommends and seeks agreements from the patients on a goal, usually reduced drinking, for example. With motivational interviewing, as we saw, is more about exploring patients' beliefs and perceptions. So this technique throws the decision to quit or reduce drinking and to find the best method back onto the individual. In this case, the therapist asks targeted questions that prompt the individual to reflect on their drinking. When patients resist, the therapist does not argue with the individual, but explores the person's ambivalence about change so as to allow him or her to draw their own conclusions. For example, you say that you like to be in control of your behaviour, yet you feel when you drink you're often not in control. Could you clarify what you mean by that? Thinking or cognition has to be seen alongside behaviour. If behaviour doesn't change, then the therapy won't be effective. So hence this new type of therapy emerged called cognitive behavioural therapy, which is defined here as a system of psychotherapy that attempts to reduce excessive reactions and self-defeating behaviours by modifying the faulty or erroneous thinking and maladaptive beliefs that underlie these reactions. So according to this approach, disturbances in behaviour such as addictive behaviour can be modified or changed by changing and altering cognitive processes. Change your thoughts and your behaviour will follow. So while the earlier behavioural therapies had been effective for neurotic disorders, they hadn't been so successful in treating neurotic disorders. So Aaron Beck and Albert Ellis developed this new form of therapy. And this system included behavioural elements and interventions and primarily focused on presence in the problems in people's lives, as we saw when we talked about Maslow previously. One of the important foundations of behavioural and cognitive change is the trans-theoretical model, sometimes called the stages of change model. This is a model developed in the 1970s by Prochaska and De Clemente, and this evolved through their own studies examining the experience of smokers who quit on their own without requiring further treatment to understand why some people were capable of quitting on their own and why some people are not capable of quitting on their own. The important point is that each stage there is a decisional balance at which we will look at. So the model goes through these different stages. In the pre-contemplation stage, people do not intend to take action in the foreseeable future. People are often aware that their behaviour is problematic or produces negative consequences, and people in this stage often underestimate the pros and cons of making change, placing too much emphasis on the cons of changing their behaviour. In the contemplation stage, people are tending to start their healthy behaviour in the foreseeable future. People may recognise that their behaviour may be problematic, and a more thoughtful and practical consideration of the pros and cons takes place, but people still may feel ambivalent towards their behaviour. In the determination phase, people are ready to take action quite soon. People start to take small steps towards behavioural change. In the action phase, people have recently changed their behaviour and intend to keep moving forward with this behavioural change. There's also a possible relapse phase here where people slip backwards. In the maintenance phase, people have sustained their behavioural changes and intend to maintain their behaviour going forward. So cognitive behavioural therapy is a short-term, comparatively brief approach. It has been evaluated in trials and there is empirical support as a treatment for drug and alcohol abuse, although the extent of that support is debated. CBT is a structured, goal-orientated approach and focuses on the immediate problems faced by drug users. So we can see here that cognitive behavioural therapy involves helping to help clients recognise situations, avoid these situations where appropriate, and cope more effectively with a range of problems and problematic behaviours. So these principles of cognitive behavioural therapy, they might seem a bit abstract, so let's look at a case study to illustrate them. This is a case study reported in the Indian Journal of Psychiatry. So we start with Rajiv, a 45-year-old gentleman presented with a long history of alcohol dependence. His father and maternal uncle were heavy drinkers. So in this narrative, you can see what they're doing is looking at the behavioural and cognitive aspects of the drinking. So in this case, it's identifying predispositions to drinking and social learning. Rajiv was anxious since childhood, so there's early learning factors involved, and he avoided social situations, so poor coping strategies. He started using alcohol in college with friends and found that drinking helped him to cope with anxiety. Gradually, he began to drink before meetings and interactions. And so this indicates maladaptive coping and negative reinforcement. Negative reinforcement is something that occurs when a stimulus is removed after a particular behaviour is exhibited. So the likelihood of this behaviour occurring again is increased because of removing the negative consequences. So in other words, the anxiety is removed by drinking. So here we can see the beginnings of using behavioural theory, which we'll look at later, to explain behaviour. So his alcohol consumption increased and began to affect his work. He reported difficulty sleeping if he did not drink, and he could not get past the day without drinking. So here we can see the establishment of a pattern of dependence. In the next phase, we can see that Rajiv could not retain jobs due to his frequent absence. His wife brought him for treatment, but he was not keen on help. He didn't believe it was a problem. And again, we can see reference to the stages of change model here. He believed that drinking helped him across many domains of life, so there was positive outcome expectancies regarding his alcohol use. So what Rajiv's therapist did was identify antecedents associated with drinking, such as specific friends, his brands of alcohol, places that he drank, etc. He craved for his drink, thought about it often during the course of the day. So we can see the identification of cues to drinking, and this will help the therapist in helping Rajiv to change his behaviour later on. Next, we see that Rajiv had tried on many occasions to stop drinking, but he'd been unsuccessful. He reported low confidence in remaining abstinent. At the start of therapy, Rajiv was not confident of being able to help himself. So we can see that self-efficacy and relapse are issues. At the start of treatment, Rajiv was not keen to engage in the process of recovering, having failed at multiple attempts over the years. So we can see that there's many issues involved due to motivation to change, influence of past learning experience. So Rajiv's problem is an illustration of how various psychological, environmental and situational factors are involved in the acquisition and maintenance of substance abuse. So his therapist identifies strategies to enhance his motivation, to help him engage in therapy, deal with craving, and reduce social anxiety, and deal with beliefs about alcohol use. Fourthly, Rajiv's unsuccessful attempts at abstinence lead to a low sense of self-confidence and a belief that he would not be able to help himself. So there's two important concepts that have been widely researched in this area that relate to this. One is alcohol-related outcome expectancies, which refers to the anticipated effects of drinking, such as increased confidence, better sleep, etc. Rajiv's belief that drinking made him more confident, for example. And self-efficacy expectancies refer to an individual's beliefs about his or her ability to successfully execute a coping response, so we can see that there's low self-efficacy in Rajiv's case. The concept of self-efficacy is central to many health behaviours requiring self-regulation on the part of the individual. Perceived self-efficacy is an important variable in relapse prevention models. So the first step in planning a cognitive behavioural treatment programme is to carry out a functional analysis to identify maintaining antecedents and set treatment targets and select interventions. So part of that is what we saw in the last few slides. As seen in Rajiv's case, internal cues and external cues were identified as triggers for his craving. Subsequent inadequate coping and lack of assertiveness and low self-efficacy maintained his drinking. Having carried out this analysis of Rajiv's behaviour and cognitive functioning, the therapists are able to plan a series of measures designed to deal with the issues that were identified to modify and change his addictive behaviour. Cognitive behavioural therapy has been described as a well-established evidence-based treatment for substance misuse with demonstrated effectiveness in a range of studies. Meta-analyses have reported small but significant effects of CBT at reducing substance use rates across a wide variety of substances, with the largest effect found for marijuana and cocaine. However, it's also faced criticisms such as the mixed effect on retention into treatment, limited focus on patient motivation and engagement, as well as the challenge of implementation in community clinics. Combining CBT with motivational interviewing, as we've seen, is one approach to address these weaknesses. Are there any drawbacks to cognitive therapy? The biggest problem with cognitive therapy and behavioural therapy is the amount of work to be done by the patient. Because these types of therapy are active, people who are not interested in working on it almost every day are not likely to benefit very much from it. So we return again to the points illustrated by the stages of change model. Another criticism that's been made is that cognitive restructuring exercises, with their emphasis on reframing reality and not changing it, do not deal with the true problem. Also important in these therapies is people's level of cognitive functioning, as several studies have found that poor cognitive functioning is associated with earlier treatment dropout, fewer skills acquired, and poorer outcomes. Cognitive behavioural therapy, as we've seen, is considered a cognitively demanding tasks, and often individuals enter treatment with cognitive deficits. So increasingly, there have been studies looking at how these cognitive deficits themselves can also be addressed. The trans-theoretical model focuses on the decision-making of individuals and is a model of change. The model operates on the assumption that people do not change behaviours quickly and decisively. Rather, change in behaviour, especially habitual behaviours like addiction, occurs continuously through a cyclical process. For each stage of change, different interventions strategies are more effective at moving the person to the next stage of change and subsequently through to the level of maintenance, which is the ideal stage of change. And decisional balance is an important part of the model, where each stage we look at the potential gains and losses of behaviour. So two components of decisional balance, the pros and the cons, have become core constructs of the stages of change model. And as individuals progress through the stages of change, decisional balance shifts in critical ways. So let's look at the decisional balance. When an individual is in the pre-contemplation stage, the pros in favour of behavioural change are outweighed by the relative cons for change and in favour of maintaining the existing behaviour. In the contemplation stage, the pros and cons tend to carry equal weight, leaving the individual ambivalent. If the decision balance is tipped, however, such that the pros in favour of changing outweigh the cons, many people move to the preparation or the action stage. As individuals enter the maintenance change, the pros in favour of maintaining the behavioural change should outweigh the cons and decrease the risk of relapse. So there are many strategies associated with the decisional balance. So one, for example, might be consciousness raising, increasing awareness about the healthy behaviours. Dramatic relief involves emotional arousal about the health behaviour, whether in a positive or a negative way. Self-reevaluation, self-reappraisal to realise that healthy behaviour is part of who they want to be. Environmental reevaluation involves realising how unhealthy behaviours affect others. Helping relationships, finding supporting relationships that encourage the desired change. Substituting healthy behaviours and thoughts for unhealthy behaviours and thoughts. And another one is reinforcement managing, rewarding the positive behaviour and reducing the rewards that come from negative behaviour. Also, stimulus control involves re-engineering the environment to have reminders and cues that support and encourage healthy behaviour and remove those that encourage the unhealthy behaviour. So these are some of the strategies that can be used to alter the decisional balance. Also important is the idea of locus of control. Locus of control is the degree to which people believe that they, as opposed to external forces, have control over outcomes of events in their lives. The concept was developed by Julius Rotter in 1954 and is conceptualized on a scale between internal, which is a belief that one can control events in one's own life, to external, a belief that life is controlled by outside factors that a person cannot influence. Sometimes locus of control is seen as a stable underlying personality construct, but this may be misleading since both theory and research indicates that locus of control is largely learned. Some psychological and educational interventions have been found to produce shifts towards locus of control. For example, participating in an outdoor education program. Outcome expectancies is another concept defined as the costs and benefits expected to result from a change in behaviour. Outcome expectancy can be health-related or not health-related. So in terms of how these concepts relate to addiction, there are a few studies. This study by Haynes and Aycliffe in 1991 asked the question, locus of control is high externality associated with substance misuse. And they found that active substance misusers had higher external locus of control than non-users. And they noted that where cognitive behavioural therapy is used, they would expect an increased internality to predict behavioural change maintenance. Another study by Solomon and Annis in 1991 looking at outcome expectancies found that outcome expectancies did not predict alcohol consumption at post-treatment, but belief in self-efficacy did. An interesting question is how do these factors change during treatment? The extent to which these factors change during treatment could facilitate our understanding of how people transition out of an addictive lifestyle. And this study reports on 101 participants in an alcohol treatment program. And people were assessed at the beginning and at the end of treatment. And few studies have examined correlates of changes in these expectancies. So we'll just look at a couple of findings from the study. So they begin by noting that alcohol effect expectancies and efficacy are both important factors. And the analysis confirmed their predictions that effect expectancies and self-efficacy were inversely correlated at the beginning of treatment, and that both alcohol expectancies and self-efficacy changed significantly during the treatment program. So there was larger decreases in expectancies for individuals who entered treatment with less confidence in their ability to resist drinking compared to those with more confidence in potential drinking situations. So the results suggest that both expectancies and self-efficacy are useful factors to target in alcohol treatment. So when people are faced with temptation, are there any strategies available that can help to reduce the value of the tempting task and do something else? This was the topic of a study by Megan and Gross, who proposed a strategy to reduce temptation, namely cognitive reappraisal. This involves changing the meaning of a situation so as to decrease the value of the temptation. So the goal of their study was to examine the impact of reappraisal and performance in an ecologically valid context. This was searching for information on the internet without being distracted by unrelated content. And this is something that's frequently encountered by a student, especially with the temptation is inherent to the task. When it's available, all the information is available on the same website, so the temptation cannot be ignored. And they hypothesized that compared to participants in a control condition, Participants who reappraised the task as a diagnostic of willpower would perform better in the task. So this slide shows the task here. They had to search for information on the internet while resisting attractive task irrelevant content. So in the reappraisal condition, participants received the following instructions. You've done half the study. I will now ask you to perform the same task again, but on a new website. The next task aims to assess your willpower. Please do your best to answer as many questions as possible. And the results showed that participants who used reappraisal performed better in the task. So what they suggest is that reappraisal seems to inoculate participants against the potentially harmful effects of lack of self-control. So, okay, that works well in this situation. Could it also be applied to addiction? That's the question for us to think about. Two key concepts in cognitive behavioural therapy derived from learning theory. And we'll look at two types of learning theory. We'll look at classical conditioning and operant conditioning. Classical conditioning helps us to understand factors involved in triggering drug use and craving. And to some extent, these can affect self-efficacy. If there are things that are triggering drug use, then these are factors outside our own control. Operant conditioning looks at the reward and punishment in relation to addictive behaviours. So how do rewards and the outcomes affect patterns of addictive behaviour? During the 1890s, the Russian physiologist Ivan Pavlov was researching salivation in dogs in response to being fed. And what he discovered was that when two stimuli are linked together, they can produce a new learned response in a person or an animal. So this is the apparatus that Pavlov was using, and we can see the dog being fed and the saliva is being recorded here. So what he found was when an animal is being fed with food, the animal salivates. So the unconditioned stimulus is food and the unconditioned response is salivation. To begin with, if there's a neutral stimulus, for example, like a metronome, it doesn't produce any response at all, so there's no conditioned response. But if just before the animal's about to be fed, the metronome is sounded, the metronome will elicit a response, and even later when the animal hears the metronome and there's no food, it will still elicit this conditioned response. So that's the key factor of classical conditioning, is that a conditioned stimulus can elicit a conditioned response even when there's no unconditioned stimulus present. Of course, this effect varies over time, but this is the basis for the triggering of behaviour. If a conditioned stimulus can trigger a behaviour, this is a powerful factor, and that's one of the things that seems to be involved in drug addiction and is something that cognitive behavioural therapists look at. So the way in which classical conditioning may operate in relation to drug use and addiction is as follows. We have an unconditioned stimulus which naturally triggers a response. This is the unconditioned response, and this is unlearned. It's a natural response to the unconditioned stimulus. So, for example, somebody takes drugs and they feel happy. We then have the conditioned stimulus, which is previously neutral. It doesn't have any effect on the response. And this becomes conditioned, as I've explained previously. And so what we have is the conditioned stimulus becomes related to the conditioned response. So we get a learned response forming. So for example, the setting in which people take drugs becomes linked to the drugs, and it then elicits the conditioned response. And we also have the phenomenon of generalization, where not the exact same stimulus but similar ones will also elicit the conditioned response. A key aspect of addiction is craving for the substance or whatever the other activity is, and classical conditioning may play an important role in that, using the principles that we just talked about. We can see here the portrayal of, we've got drugs here leading to unconditioned response of happiness. This becomes conditioned with the sites and the paraphernalia associated with drugs. And so when somebody's in the presence of these, they crave the drug if there's no drug presence. And there have been therapies that have tried to use this principle of classical conditioning to try to undo the craving. So for example, if you keep presenting the conditioned stimulus without the unconditioned stimulus, then eventually you'll get extinction of the conditioned response. So that's one principle that has been used to try to treat addiction. Pavlov's work gave rise to a movement in psychology known as behaviorism. In 1913, John Watson, shown here, published his classical article, Psychology as the Behaviourist Viewed It. And Watson believed that classical conditioning was an extremely important principle which explained many aspects of human behaviour. In one experiment, which known as the Little Albert experiment, he took a young child and placed it on a mattress in the room. There was a white rat placed near the child called Albert, and he was allowed to play with it. At this point, the child showed no fear of the rat. He began to reach out and played with it. In later trials, however, Watson made a loud sound behind Albert's back by striking a suspended bar with a hammer when the baby touched the rat. Not surprisingly, on these occasions, Albert cried and showed fear as he heard the noise. After several pairings of the two stimulus, Albert was again presented with only the rat. Now, however, he became distressed. So what the process was that Albert had associated the white rat, which was the original neutral stimulus, now the conditioned stimulus, with the loud noise, which is the unconditioned stimulus, and this produced the fearful or emotional response of crying, originally the unconditioned stimulus. The experiment led to the following progression of results. The experiment showed that little Albert seemed to generalize his response to any furry object that Watson presented to the child. So Watson was able to show that fear of objects was in this case also conditioned. Watson realized that this principle could be used to modify human behavior, and after he left academia, he started the world's first advertising agency and became a millionaire as a result of using Pavlovian principles. We can see those principles every day when we see advertisements, for example, in this case for a beer. So we can see that the unconditioned stimulus is the beach and nice weather. The unconditioned response, when we see that, is being happy. So to the unconditioned stimulus of the beach is now added the beer, and this elicits the conditioned response of being happy. So we can see these principles being used every day in advertising. And as it says here, over time, the controlling properties transfer from one to the other. So the power to elicit pleasure transfers from the beach to the beer. The role of relapse and re-addiction was explored in a classic 1965 paper by Thompson and Osland, called susceptibility to re-addiction as a function of the addiction and withdrawal environments. In their study, what they did was, first of all, they made rats addicted to an oral morphine solution. The rats were then withdrawn, and then they were re-exposed in either the same environment or a different environment. And what they found was that rats who were re-exposed in the same environment drank more morphine. In other words, this is the conditioned stimulus that we've been talking about. In another study, monkeys showed withdrawal signs when music associated with morphine injections was played after several months drug-free. So we can see from these studies the importance of triggers. And in a classic paper in Psychological Review in 2014 called Addiction Motivation Reformulated, they explore this idea in more detail, and they develop what they call the negative reinforcement model of drug addiction, in which they propose that escape and avoidance of negative effects is the main motive in addictive drug use. The authors posit that the negative effect, in other words the withdrawal, is at the motivational core of drug use, and argue that through repeated cycles of drug use and withdrawal, people learn to detect the signals of negative effect pre-consciously. So this is important because what they say is that the motivational base of much drug use is not available in consciousness. So when stressors cause negative effect to grow, increased negative effect promotes new drug administration. So this model, which is quite a complex model, but it might suggest why cognitive behavioural therapy is a difficult therapy and doesn't always work for addiction, because much of the many of the factors involved in addiction are not conscious. Now we're going to look at a second type of learning which is important in addiction, and this is called operant conditioning as opposed to classical conditioning. So here we see the classical conditioning setup that we looked at earlier, the dog and the food, and it's quite passive. The dog is quite passive. If something happens like a bell being rung, then it causes salivation, so there's no voluntary control. The contrast is shown with the setup in B.F. Skinner's chamber called the operant conditioning chamber, in which the rat is not constrained in any way. It can press on this lever or not press on this lever, and there will be consequences for their behaviour. So it's more to do with the way that the animal operates on the environment and the consequences for that behaviour. Classical conditioning involves then making an association between an involuntary response and a stimulus, while operant conditioning is about making an association between a voluntary behaviour and a consequence. In operant conditioning, the learner is rewarded with incentives, while classical conditioning involves no such enticements. And as we've said already, classical conditioning is passive from the part of the learner, while operant conditioning requires the learner to actively engage. And it's this second type of learning, operant behaviour, which Skinner and others came to believe was far more important for explaining people's behaviour, and that many types of behaviour are governed by the consequences, not what happens before the behaviour. So you study for an exam because of the consequences. You want to get a good grade for that exam. You participate in an athletic race because you want to win the race. Of course, people have known these principles for years, but what Skinner did was to study them experimentally. And in 1948, he wrote a novel called Walden 2, in which he describes a community of people whereby their behaviour is scientifically controlled by this principle. Interestingly, it was written in this same year that George Orwell published his book 1984, and the contrast is that in 1984 people's behaviour is controlled through punishment, but in Walden 2 it's controlled through reward. Still, some people didn't like Skinner's approach because they argue that it denies the concept of human freedom. What Skinner's response to that is, it's just because we're not aware of the contingencies of our behaviour. We're not truly free. We're actually controlled by the contingencies. So quite a provocative novel when it was published. And Skinner's most important work was in the studying behaviour in the Skinner box, which we saw earlier, in which the behaviour of rats and other animals pressing levers in response to different patterns of reward was studied extensively and described in this 1957 book, Schedules of Reinforcement. And what Skinner did was he studied 4 different types of reward. He looked at where you're rewarded, for example, every 5th time that you do something. So these are called ratio schedules. And he also studied schedules where you're rewarded after every 2 minutes, say, for doing something. And he looked at 2 variations of these, one in which the rewards were fixed, so every 5th time you get a reward, or variable, so on average it's the 5th, but it could be the 3rd or the 7th, and similarly with the time. And the steepness of this line indicates how often the animal or the person is responding. And we can see that for fixed and variable ratios, the responding rates are very high, because time isn't a factor here. Just the more you respond, the more you'll get a reward. We see in the intervals, we see periods of responding, and then after the reward, the behaviour drops off, and then it picks up again towards the time where a reward is possible. So this was very important work in describing how people respond to the consequences of the behaviour. And this is just a very simple overview. It can get much more complex than this when, for example, there are multiple responses with different schedules associated with them. And here are some examples. You can probably think of many others of types of behaviour that can be explained by operant conditioning. So for example, with a vending machine, we put money in and we get something out of the vending machine. This is an example of continuous reinforcement. If we didn't get something out of the vending machine, we might try it once more, but our behaviour would be rapidly extinguished. That's why continuous reinforcement is not a good way of maintaining a high level of behaviour. However, if we look at slot machines variable ratio, we know that we'll get a reward every so often, every 5 or 10 responses, and this can result in a high rate of behaviour. Checking email is another example of this. People obsessively checking email expect to get something every 2 or 3 minutes. They don't know exactly when, but again, this will result in a high level of behaviour. However, we know that our actual physical post only comes once a day, so there's no point in checking the post box repeatedly, because we know that we only get rewarded occasionally. And if we look at assembly line production, if a worker gets paid for every 10 items she makes, we will get again the high level of behaviour associated with fixed ratio schedules. So what this led people to do was to look at behaviours and do a functional analysis of the behaviour. So we have a behavioural problem. We can look at the frequency. We can identify the contingencies that are associated with that. You know, why is it being rewarded? We can develop interventions and so on. So this led to a school of therapy based on Skinner's work. One technique that's been used in treatment is called contingency management, and this is based on operant conditioning. Contingency management refers to a type of behavioural therapy in which individuals are reinforced or rewarded for evidence of positive behavioural change. The schemes target a wide range of behaviour, for example, quitting smoking and eating less. We're probably all familiar with rewarding ourselves for behavioural change, for example, studying for an exam followed by giving yourself a treat. So the contingencies refer to the contingencies of reinforcement, which is a phrase that B.F. Skinner used in describing his research. Interventions usually use vouchers as reinforcements, but a new technique looked at awarding prizes instead. The study looked at 142 cocaine or heroin-dependent outpatients, and they were randomly assigned to either getting standard treatment with vouchers, or standard treatment with prizes for 12 weeks. The contingency management patients, irrespective of whether they got prizes or vouchers, did better than the standard treatment approaches. Thus, prize and voucher systems appear to be equally efficacious in promoting abstinence among drug users. If contingency management is so effective, why is it not used more frequently? This paper here looks at the process by looking at a qualitative evaluation of a contingency management intervention. And what they found was that while theoretically it's quite clear, implementing it in practice involves controlling lots of aspects of the environment. And because of this, it's a relatively complex approach to actually achieve in practice. So far, we've looked at the situation involving one behaviour, but in the real world, people are engaged in all sorts of behaviours every single day. So how do people distribute their behaviour? In particular, how do they distribute their behaviour with regard to addictive behaviours and non-addictive behaviours? This is the topic of a paper by Gene Heyman, and in it he looks at one principle of operant conditioning that people have studied, which looks at different responses. And the idea is that depending on situations, people either maximize their behavior or they match their behavior, sometimes called melioration. In maximizing, people distribute their responses among various alternatives so as to maximize the overall amount of reinforcement over the long run. Whereas in matching or melioration, people respond so as to improve the local rates of reinforcements for responses. Behavior keeps shifting back and forward between the two alternatives until ratios are equals, which is why it's called matching. So under maximization, it's argued that people could not gradually slide towards a very high level of drug use at the expense of other activities, because the level of reinforcement would fall, and people would want to try and maximize the overall amount of reinforcement they would get. So in other words, the long-term negative consequences would have an impact. The reinforcement power would be reduced because of the negative consequences. However, under matching, the same values for drugs and other conventional activities can lead to a higher level of drug use, because longer-term considerations do not have such an impact on current behavioural choice. So this was an attempt to use the principles of operant conditioning to try to explain how addiction might occur. So in the paper by Heyman, he goes on to think about this more, and what he says is when drugs are inaccessible and choices are under scrutiny, so for example when somebody is in treatment, an addict is more likely to favour not using them. But when he goes out back into the real world and the drugs are available, he will reverse himself, so he's more likely to match. But in general, little is known about the conditions under which people match or maximize their behavior. There are many questions associated with matching or maximizing. Over what time periods are comparisons made? Does recent experience carry more weight? I think the key point here is that both drug use and whether people choose to stop using drug is not a function of whether drug use is voluntary or compulsive, but it depends on the contingencies of reinforcement. And drugs are a particular form of reinforcement which make desistance difficult for addicts. And in this paper here, we discuss whether the criminal justice system can help drug users desist. One thing that Heyman points out is that drugs are a unique source of reward, and one implication of this is that drug use precedes the number of competing reinforcers that can substitute for the drug decreases. We know that many drugs are potent reinforcers. For instance, in a frequently cited experiment by Aigner and Bolster, monkeys strongly preferred cocaine to food and would have starved themselves to death if experimenters had not intervened. Although it's worthwhile contrasting this with the rat park experiment that we talked about earlier. So one of the things that Heyman talks about is that we weren't designed by evolution to consume drugs. So whereas with things like food, there's an evolutionary limit, we don't have that evolutionary limit, and so we'll keep consuming drugs. One is that we can't really compare drugs to other activities. There is not something that can substitute easily for the drugs. And therefore, drugs are likely to subvert the value of competing activities. So one thing that Heyman points out is that other things become less important in a person's life. The value of other things decreases, and therefore, if we look at this in terms of matching, you can imagine that the ratio of the drug consumption to other activities will change such that people will spend more time on drugs and less on the other things which have less potential to reinforce the person. We've looked at learning theories in relation to addiction. We're now going to look at a completely different type of theory, which is to do with how we go about explaining behaviour, and then we'll see how that might have relevance to addiction. So the theory in question is attribution theory, and it's based on Kelly's ANOVA model, ANOVA standing for analysis of variance. So let's start with a situation that we might see and think, how do we go about explaining that situation? So suppose we observe that in a classroom, Tom is hitting Mary, and that we have information available of whatever type. It could be observations, second-hand reports, our own stereotypes, and so on, about the pattern of consensus, consistency, and distinctiveness surrounding this act. So that's where the analysis of variance comes in. Kelly suggests that there's three factors involved in deciding how we go about explaining this situation. So consensus involves are other people also hitting Mary, in which case there would be high consensus. Consistency, is this something, does this person do this thing repeatedly or regularly? So does Tom do this regularly? In terms of the last point, distinctiveness, is Mary the sole recipient, or do other people have this done to them also? So those are the three factors involved. And by varying these factors, we can see how people come up with different explanations. For example, it is only Mary who hits Tom, low consensus. He seems to hit Mary quite often, and he also hits other girls in the class. So we have low consensus. It's only Tom. He seems to hit Mary quite often. High consistency, and he also hits other girls. Low distinctiveness. So in this situation, we have an attribution of low, high, low, and we're likely to explain this event in terms of a negative property of Tom. He's aggressive, for example. And we can imagine if we change the way in which we look at these three different things, we would come up with completely different explanations. So for example, imagine that there's high consensus. Other children also hit Mary. High consistency, they also hit her often. And these children are not generally noted for hitting other people. In these circumstances, we're likely to attribute the act to some disposition of Mary, perhaps to something that she's doing that's annoying people. So depending on what information we have about a situation will result in how we go about explaining it. Of attribution theory, and he applies it to addiction. Rather than the normal dedication page at the start, we see this. He says, I wrote this book because I wanted to. Nobody made me do it, and I did it on purpose. I was certainly not forced into it by circumstances. Finally, I wrote it for me. It would be dishonest to attribute it to some other person. So you can see here the attributions that he is making about the book, and you can probably see how he's going to use this to think about addiction. So current views of drug dependence tend to emphasize individuals struggling to overcome an internal compulsion. This compulsion, whether it's pharmacological or cognitive, is seen as central to understanding dependence, and it's become synonymous with a medical approach that considers addictive behaviour in terms of an underlying disease. So the book is partly a review of scientific literature, and it's partly a review of how people construct explanations. And his argument is that addiction overlooks the voluntary component, and this is damaging because it denies feelings of efficacy to the users. So what he's saying is that theories that emphasize the compulsive and medical approaches to addiction are actually harmful because they take away from people's feelings of self-control. And so this approach is not really looking at addiction as a learning phenomenon as we looked at previously, but saying that it's due to faulty attributions and language that are at the core of understanding addiction. So in the book, he considers two types of explanation. Explanation one, most people who use drugs do so for their own reasons, on purpose, because they like it and because they find no adequate reason for not doing so. Explanation two, they fall prey to an addictive illness which removes their capacity for voluntary behaviour. So why do people tend to go for this second explanation? He argues that it's because people need to see addiction as a malfunction, something that's gone wrong, and absolving blame, so the person's not to blame for their person. He argues that the second type of explanation is generally preferred because it's functional for drug users to report that they are addicted and driven into drug use by forces beyond their capacity, and secondly, it's functional for therapists to be the necessary agent of change. So the central argument of the book is that self-reports have their own internal logic which is independent of reality, and that if we used other research methods and forms of analysis, we would have a different picture of addiction. So here I've taken Davis's ideas and tried to develop a framework for considering two factors. One is the locus of control, is it internal or external? And one is whether it's a stable or unstable attribute. So we look at problematic drug use and look at some possible consequences. If we see drug use as something that's internal to the user and it's a stable attribute, in other words, it's the effects of drugs on the brain, then we might conceptualize problematic drug use as a disease and think that it needs medical treatment to deal with it. If, on the other hand, we see drug use as it's internal to the person, but it's unstable, it's not affecting the brain, it's something to do with individual choice depending on all sorts of circumstances, then we might go down the route of punishing people who use drugs. Alternatively, we could consider drug use as being something that's external and stable. So, for example, it could be a bad environment that's causing drug use, and therefore we might target social exclusion as a factor. Finally, another explanation could be that it's external, but it's unstable. It just depends on, for example, high availability of drugs at certain points. And in this scenario, what we would do would be to target suppliers. So you can see how attribution theory, depending on the types of information that we have or ideas about addiction, can lead to different attributions of what addiction is and how it should be dealt with. So in John Davis's view, he thinks that most of us want to attribute addiction to a disease or biological model rather than free will. To some extent, his views are similar to existential philosophy found in the book Being and Nothingness by Jean-Paul Sartre, and also in the novel Nausea, in which he developed his idea of existentialism and the way in which people make choices. In Being and Nothingness, Sartre is extremely critical of psychological theories, for example, psychoanalysis, which in any way negate human freedom. So attribution theory portrays the addict playing a role in which addicts are condemned to represent themselves as addicts, as long as the dominant view of drug addiction remains in force. Whereas existentialism offers the choice of an authentic life based on the drug user's choices. Attribution theory places the drug user in a web of social and medical relations, which are the determining agents of how drug use is perceived in society. How does this relate to our earlier ideas about operant conditioning and matching? Learning theory tries to explain choice based on contingencies of reinforcement. So it's a psychological theory which existentialism would reject. So in the end, we're left with different ways of explaining addiction.